Okay, imagine this. You're getting ready for a pretty major surgery. Maybe it's that hip replacement you've been waiting for, or, a heart procedure, something significant. You've done all the prep, focused on the physical side, the rehab, getting back to normal. But have you thought about the mental recovery? What if, when you wake up, you or maybe a loved one feel lost, kind of adrift in this weird, disorienting, uh, pharmacologic fog? It's much more than just feeling groggy. That's exactly what we're diving into today, this often unseen but really impactful part of surgery. Our focus specifically is post-operative delirium, POD for short. And this isn't just some fancy medical term, it's a real acute state where the brain isn't working right. We're talking fluctuating problems with attention, with awareness, with just thinking straight. It's like your brain's navigation system is temporarily offline after the stress of surgery,
Right.
way beyond simple confusion.
Yeah, absolutely. And our mission, really, is to give you a shortcut, a concentrated guide to understanding this critical, but often, frankly, overlooked part of recovery.
Mm-hmm.
Specifically, how certain medications can actually cause this state, or at least push someone towards it. We're pulling out the key insights from our sources on how avoiding these specific high-risk meds around surgery time, that's the perioperative period, can seriously cut the risk of POD.
So why should you care about this? Why is it important? Well, POD isn't just a minor blip. It's a serious complication, and it's surprisingly common, especially in older adults. And when we say serious, we mean it can lead to a whole cascade of pretty devastating outcomes. Things like much longer hospital stays, an increased chance of needing nursing home care instead of going home, cognitive problems, memory, focus that can linger for months, maybe even years.
And sadly, yeah, even higher mortality rates, it's a big deal. But here's the crucial part, the hopeful part maybe. Medication management is one of the biggest modifiable risk factors.
Yeah.
It's something we can actually do something about,
Yeah.
a real point of intervention.
Okay, so let's really get into it then. To understand how to intervene, we need to understand the landscape. Post-operative delirium. You said it's more than grogginess. What is it, really, at its core?
It's that acute brain dysfunction we mentioned.
Mm-hmm.
Think of it less like being sleepy and more like the brain's internal wiring getting scrambled temporarily. It struggles to process what's happening, maintain focus, stay connected to reality. And our sources are really clear. This is not benign, not at all. They actually use the phrase cascade of devastating outcomes, which really hits home how serious it is. It's a disturbance of consciousness, often comes on quickly, and the symptoms can fluctuate wildly. A patient might seem okay 1 minute and then completely confused the next.
Cascade of devastating outcomes. Yeah, that is unsettling. How common are we talking here, especially for older folks undergoing surgery?
It's disturbingly common. The numbers vary depending on the surgery type, the patient's health, how it's diagnosed. But studies suggest anywhere from 10% to even 50% of older adults having major surgery might experience it. And for really high-risk stuff like hip fracture repairs, major heart surgery, those numbers can shoot up even higher, sometimes over 60% in very frail patients. It's a major public health issue, not just some rare event.
Wow. That's a lot higher than I think most people would guess. And those long-term consequences you mentioned, beyond just being confused in the hospital, what does that look like day to day for patients and families?
Well, the impact can be really profound, and it can last. First, longer hospital stays. That means more time away from home, more risk of hospital infections, slower recovery overall. That's almost a given. But maybe the most shattering thing is that increased risk of needing long-term care. A lot of patients who get POD, especially if it's severe or lasts a while, find their thinking, their memory, attention, planning skills just doesn't bounce back to where it was before. And that can mean losing independence, maybe needing to move into a nursing home or assisted living, even if they were living fine on their own before the operation. It's heartbreaking. And then there's that long-term cognitive decline. It might show up as ongoing memory issues, trouble concentrating, just feeling mentally slower. Or it could even speed up an underlying issue like Alzheimer's. It's not just a temporary cloud. It can leave a real mark.
Yeah.
And yeah, the tough part, the higher mortality rates are consistently linked to POD. It really signals that the person's system is vulnerable, struggling to cope with the stress.
So it's almost like a symptom itself, a red flag showing the body and brain are under immense strain. The sources say the cause, the etiology is multifactorial. Lots of things playing a role.
Exactly right. It's complex. Think of it as a mix of the patient's own vulnerabilities, what they bring to the situation, and then the specific triggers or insults around the time of surgery. So the vulnerabilities might be age, existing memory problems, frailty. The insults could be the surgery itself, an infection, pain, not getting enough fluids, being in a weird hospital room, all sorts of things.
Okay. And critically, A major category of those insults, those triggers, are iatrogenic, meaning caused by medical treatment. And right at the top of that list, high-risk medications. That's the piece we can often control.
Got it. And that's our focus today, those medications. But before we list the specific drugs to watch out for, why? Why are certain drugs so bad for the brain in this situation? What's happening biologically?
Yeah, this is where it gets really interesting and maybe a little alarming. We don't have the complete picture of delirium's neurobiology, but the leading ideas point to what our sources call a perfect storm hitting a vulnerable brain. Imagine the brain's delicate chemical balance. Surgery and certain drugs can throw that balance way off. Two big players here are neuroinflammation and neurotransmitter imbalance.
Neuroinflammation. Okay, so inflammation in the brain. Precisely. Surgery is a trauma, right? A controlled one, but still trauma. The body mounts an inflammatory response to heal, releasing these messenger chemicals called cytokines. Normally, the blood-brain barrier, think of it as the brain's bouncer, keeps most inflammatory stuff out. But in vulnerable people, or with major surgery, that barrier can get leaky.
Ah.
These inflammatory cytokines sneak into the brain, disrupt how neurons talk to each other, cause stress, basically gum up the works.
So the body's healing response can accidentally cause trouble upstairs?
Wow.
And the other part you mentioned was neurotransmitter imbalance, chemical messengers getting out of whack.
Yes, and this is absolutely key to understanding why certain meds are such culprits. The cholinergic deficiency hypothesis is central here. Acetylcholine is a super important neurotransmitter. It's crucial for memory, for paying attention, for learning, for processing information. The theory is that a drop in acetylcholine levels is a major driver of delirium.
So low acetylcholine, it's like the brain's operating system is low on RAM or something. It just can't keep track, can't focus.
That's a great way to think about it. The communication lines get fuzzy or cut off. It cripples the ability to think clearly. And while low acetylcholine is a big one, it's not the only player. Often you see too much dopamine, which can cause agitation, restlessness, maybe hallucinations common in hyperactive delirium. And other systems like serotonin and GABA, the brain's main calming chemical, can also get disrupted. It's usually multiple systems going haywire together.
It really does sound like a perfect storm hitting the brain. So who's most likely to have this vulnerable brain? Who are the patients most at risk when they go into surgery?
Well, the risk factors are pretty well established. Top of the list, as we've said, is advanced age. Older brains often just have less resilience, less reserve.
Yeah.
But it's not just age itself. It's often things that come with age, like pre-existing cognitive impairment, maybe diagnosed dementia, maybe just subtle memory issues people haven't noticed yet. Functional dependency is another big one. Patients who already need help with daily tasks, like bathing or dressing, before surgery, they're at higher risk. And interestingly, sensory problems, poor vision, poor hearing. Imagine being in a noisy, strange hospital room and you can't see or hear well. That sensory deprivation adds to the confusion and vulnerability.
Makes sense.
Plus, chronic illnesses, kidney disease, heart failure, they all increase the risk too.
And you mentioned diminished cognitive reserve. That sounds important. What does that really mean in practical terms for someone facing surgery?
Yeah, think of cognitive reserve like your brain's buffer zone, its ability to cope with stress or damage without immediately showing symptoms. It's like having backup systems or extra processing power. Many older adults or people with early cognitive changes might be using up a lot of that reserve just for daily functioning. Their cognitive batteries are already running a bit low. So when the stress of surgery hits, especially if you add the push from an inappropriate medication, their brain just doesn't have the extra capacity to handle it. It gets overwhelmed easily and tips into delirium. They have less wiggle room.
That paints a really clear picture. They're operating closer to the edge already, and certain meds can just push them over. Which brings us right to those pharmacologic culprits, the drugs to avoid or use very carefully around surgery. This is where proactive prevention really kicks in, isn't it?
Absolutely. This starts with super careful medication reconciliation. And I mean meticulous, not just glancing at the list. It means looking at everything the patient takes, prescriptions, over-the-counter stuff, herbals, and also what might be given in the hospital. The goal is to spot the high-risk drugs and, whenever it's safe, stop them or swap them before surgery or recovery even starts.
Okay, let's get specific then. What's the first group on this avoid list? Our sources call them arguably the most potent pharmacological triggers, anticholinergic medications. Why number one?
Yeah, these are major offenders.
Yeah.
And the reason goes right back to that acetylcholine problem we talked about. Anticholinergic drugs directly block the action of acetylcholine in the brain.
Hmm.
They basically jam the receptors, the locks, that acetylcholine normally fits into.
Okay.
So they actively create that acetylcholine shortage that drives delirium. It directly messes with the brain chemistry needed for clear thinking.
So they're basically pouring fuel on the fire if someone's already vulnerable, but anticholinergic. That word isn't always on the label, right? You said some common drugs have these effects kind of hidden.
Exactly. This is a huge pitfall. Many drugs have anticholinergic side effects, even if that's not their main purpose. And the
Mm.
classic, perhaps most worrying example is first-generation antihistamines,
Mm.
specifically diphenhydramine.
Benadryl.
Yes, Benadryl. It's everywhere. Used for allergies, sometimes given for sleep in the hospital, or people take it over the counter in things like Tylenol PM or Advil PM.
Wow. Benadryl. That's in practically every home. I mean, I've definitely used it. So something that common can be a major delirium trigger for an older person undergoing surgery. That's really surprising and concerning.
It is, and it's a real public health message that needs to get out there.
Mhm.
In older adults, especially in the hospital, diphenhydramine should pretty much never be the first choice for sleep or anxiety. It hangs around in the body for a long time, builds up, and causes prolonged confusion. People mistake its sedative effect for safe sleep, but it's actively disrupting brain chemistry.
Yikes.
Other examples, older antidepressants like amitriptyline, some older antipsychotics like chlorpromazine, even some muscle relaxants like cyclobenzaprine, Flexeril, they all add to the total anticholinergic load on the brain.
So the plan is clear.
Hmm.
Find these and get rid of them if possible before surgery. Is that usually doable? What if someone really needs that muscle relaxant or antidepressant?
It can be tricky, but for high-risk patients, it's crucial. The team, including pharmacists, needs to review everything. First question, is this drug absolutely essential right now? If yes. Second question, can we switch to something safer? Something that treats the condition but doesn't have that anticholinergic punch. The aim is to reduce that burden before the stress of surgery hits.
That's a massive takeaway for listeners. Check all meds, especially OTC sleep aids, if surgery is on the horizon for you or a loved one. Okay, what's the next big category of problem drugs?
The next major group, also huge contributors to POD, are benzodiazepines and the related Z drugs. These are the sedative hypnotics, think Valium, Ativan, Xanax, and the Z drugs like Ambien, Lunesta. While they're prescribed all the time for anxiety or sleep out in the community, their risks often seriously outweigh the benefits around the time of surgery, especially for vulnerable folks.
So common drugs like lorazepam, diazepam, alprazolam, and then zolpidem, azopiclone, those sleeping pills.
Exactly those. Lorazepam, diazepam, alprazolam are the benzos. Zolpidem, isopicolone, zaloplan are the Z drugs. People sometimes think the Z drugs are safer, but honestly, for delirium risk, they're nearly as bad because they work in a very similar way.
And how do these cause problems? What's their mechanism?
They work by boosting GABA, the brain's main inhibitory or calming neurotransmitter. They essentially hit the brakes on brain activity. But it's not a gentle slowing down. It's more like widespread CNS depression. It can lead to being too sedated, breathing problems, and deep confusion and disorientation. It's like putting the brain into this deep fog that paradoxically makes delirium more likely when it tries to clear.
And it sounds like, again, older adults are particularly susceptible here.
Absolutely. Critical point. Older adults clear these drugs much more slowly because of changes in metabolism, kidney function, so the drugs build up. A dose that might be fine for a younger person can leave an older adult sedated and confused for days, especially the long-acting benzos. This accumulation dramatically increases the risk of falls, prolonged confusion, and, delirium. Avoidance really has to be the main strategy here.
Okay, but what if someone is genuinely, understandably terrified before surgery? Or they just cannot sleep in that noisy hospital room? You can't just ignore that. What are the safe options?
You're totally right. And this is where that holistic non-drug approach is king. For anxiety beforehand, good patient education explaining what will happen, calm reassurance, listening, a quiet environment, maybe having family there. Those things work wonders. For sleep afterwards, if a medication is absolutely needed, and that's a big 8, if melatonin is much, much safer, it works with the body's sleep cycle, not by knocking out the whole brain. The only time you'd typically consider a benzo perioperatively is for a specific medical emergency, like managing severe alcohol withdrawal, where not treating it is even riskier. Even then, it's the shortest acting agent possible, tiny doses, super close monitoring. It has to be the exception, not the rule for simple anxiety or sleep.
Right. Alcohol withdrawal is a different beast entirely. But using these routinely for nerves or sleep in older surgical patients sounds like playing with fire. Okay, let's talk pain. Opioids. They're almost guaranteed after many surgeries. Are they off limits too?
They're in a slightly different category, more like a necessary evil, as the sources put it. You often need opioids for severe pain right after surgery. Uncontrolled pain itself is a delirium trigger, so you can't just let people suffer.
Okay.
But their use has to be really careful, really monitored, because they're absolutely a known risk factor for POD. It's a balancing act.
So morphine, hydromorphone, fentanyl, those usual suspects. Are some worse than others?
Those are the common ones,
Hmm.
yes. And while they all carry risk, there's one huge warning: meperidine or Demerol. Our sources say avoid it completely in older adults. It's uniquely dangerous because of how it breaks down in the body.
Demerol. Why is it so much worse? What's the deal with its metabolism?
It creates a really toxic byproduct. So most opioids have metabolites that can build up, especially if kidney function isn't great, and cause sedation or confusion. Morphine 6-glucuronide from morphine, for example. But meperidine breaks down into normeperidine, and normeperidine is a potent neurotoxin. It doesn't get cleared well, builds up easily, and it actually stimulates the nervous system in a bad way.
Stimulates, not sedates.
Right. It causes agitation, tremors, muscle twitches, even seizures, and yeah, profound delirium. It's nasty stuff, especially because it can accumulate over time, causing delayed but severe problems. It's just not worth the risk in older patients.
Okay, so Demerol is definitely out for older adults. Got it. For the other opioids, how do doctors manage pain effectively without tipping someone into delirium? That sounds tricky.
It is tricky, but the strategy is opioid minimization. Not zero opioids necessarily, but the lowest effective dose. And the key to achieving that is multimodal analgesia. This is the gold standard now. It means using a combination of different non-opioid pain relievers together. They work on different pain pathways, so you get a better overall effect of synergy.
Attacking the pain from different angles.
Exactly, which means you need much less opioid medication to get the pain under control. Less opioid equals less risk of side effects, including delirium.
So what does multimodal analgesia look like in practice? What kinds of combinations?
It's layered. You might have scheduled acetaminophen Tylenol given around the clock as a baseline. Then, maybe adding an NSAID like ibuprofen or ketorolac if it's safe for the patient to target inflammation. And a really powerful tool is regional anesthesia. Nerve blocks, epidurals, things that numb just the surgical area.
Right.
A nerve block for knee surgery, for example, can provide fantastic pain relief right where it's needed without making the patient groggy systemically. It dramatically cuts down the need for IV or oral opioids. It's about being smarter, more targeted than just relying on one strong drug.
That makes so much sense. Use a team of medications working together. Okay, besides the big three anticholinergics, benzo drugs, and opioids, are there any other specific drugs or drug classes we need to flag as high risk?
Yeah, a couple more worth mentioning. High-dose corticosteroids like prednisone, often used for inflammation, can sometimes cause steroid-induced psychosis or delirium. So the rule there is lowest effective dose, shortest possible time, weigh the risks and benefits carefully.
Okay, minimize steroids. What else?
Dopamine agonist drugs used for Parkinson's disease. They can sometimes cause hallucinations or confusion, especially at higher doses or in frail patients. It's a tough balance because patients often need them for their Parkinson's, so it requires careful management and monitoring. And maybe a bit surprising, one of the older H2 blockers used for stomach acid, cimetidine tagamet, has been linked to delirium. The advice is generally to avoid it and use a proton pump inhibitor like omeprazole or a different H2 blocker like famotidine, Pepcid, which seem much safer from a cognitive standpoint.
Wow, even stomach meds. It really highlights how crucial it is to look at the entire medication picture, doesn't it? Every single pill, every IV drip. It's not just the obvious stuff.
It absolutely is.
Yeah.
Which leads us perfectly into the next point. This isn't just about avoiding bad drugs. Preventing POD needs a much broader system-wide approach. Medication management is key, yes, but it's part of a bigger picture focused on prevention across the board.
Okay, so beyond the pharmacy, what else matters? What about during the surgery itself, in the OR? Can anything be done there to lower the risk?
Definitely. Communication is huge. The whole team, surgeon, anesthesiologist, nurses, needs to know if a patient is high risk for delirium, age, memory problems, frailty. That needs to be flagged. Knowing that, the anesthesiologist can sometimes opt for delirium-sparing techniques, maybe more regional anesthesia, like we talked about, instead of full general anesthesia, if appropriate for the surgery, less systemic drug exposure, less physiological stress, and there's growing interest in using processed EEG monitoring during surgery, things like the bispectral index or BIS monitor.
BIS monitoring, what is that exactly? Like watching brainwaves?
Pretty much. It translates the complex EEG brainwave patterns into a simple number, usually 0 to 100, showing how deep the anesthesia is. The idea is to avoid going too deep. Research suggests that excessively deep anesthesia might contribute to POD. So the DIS monitor helps the anesthesiologist give just enough anesthetic to keep the patient safely unaware, but no more than necessary, titrating it carefully, avoiding that potentially harmful deep suppression.
That sounds really sophisticated. Fine-tuning the anesthesia based on real-time brain activity. Very cool. Okay, so that's during surgery. What about after? Back on the ward or in recovery? What non-drug things can help protect the brain?
This is where we really focus on supporting the brain's own ability to cope. And the gold standard here, the model program, is called the Hospital Elder Life Program, HELP. It's a whole bundle of interventions done by a multidisciplinary team specifically designed to prevent delirium and functional decline in older hospitalized patients. It's really the benchmark.
HELP, I like that acronym. What kinds of practical things does the HELP program actually involve? What are they doing day to day?
It's a set of common sense, but often overlooked, strategies. A big one is regular reorientation. Simple stuff. Reminding the patient where they are, what day it is, why they're there, using clocks, calendars, maybe familiar photos from home, just keeping them grounded. Another huge one is promoting normal sleep. Hospitals are terrible for sleep. HELP actively tries to protect sleep, minimize nighttime checks, cluster care, provide earplugs, eye masks, keep things quiet. Let the body's natural rhythm take over instead of reaching for a sleeping pill.
Right, let people sleep. It seems so obvious, but you're right, it often doesn't happen. Waking people up for routine vitals when they finally drifted off.
Exactly, it requires a real culture shift. Then there's early mobilization. Get patients moving as soon as it's safe, even just sitting in a chair, walking to the bathroom. Bed rest is terrible for cognition in older adults. Movement stimulates the brain. Making sure they're drinking enough and eating well is also critical. Dehydration and malnutrition are direct hits to brain function, so encouraging fluids, offering food they like, helping them if needed. And finally, something so simple but often missed, correcting sensory deficits, making sure they have their glasses on, that they're clean, making sure their hearing aids are in, batteries working. If you can't see or hear properly, the world becomes much more confusing and isolating.
That makes total sense. If your window to the world is blurry or silent, of course you'll feel more lost. So how do all these non-drug things, the HELP strategies, connect back to avoiding the risky medications we started with?
Oh, the connection is incredibly direct and powerful. When you implement these non-pharmacologic strategies effectively, you drastically reduce the reasons why someone might need a risky medication in the first place. If a patient is oriented, sleeping better, moving around, hydrated, and can see and hear, they're far less likely to become agitated, anxious, or unable to sleep naturally,
Oh, I see.
which means there's much less perceived need to give them a benzodiazepine for anxiety, or a Z drug for sleep, or even extra opioids because they're agitated. It breaks the cycle. Good non-drug care reduces the demand for bad drugs, which further reduces the risk of delirium. It's
Yeah.
a win-win.
This has been incredibly informative, a really crucial deep dive into something that, honestly, probably isn't on most people's radar before surgery. Let's try and wrap this up, bring the key threads together.
Sure. So fundamentally, post-operative delirium is the brain struggling, failing to cope with the massive stress of surgery. And medications, as we've really hammered home today, are often that precipitating straw, the thing that pushes a vulnerable brain over the edge. The way forward, the path to reducing this, involves being really smart and careful with pharmacology, avoiding those high-risk drugs like anticholinergics and benzos, minimizing opioids using multimodal techniques, but just as importantly, embracing comprehensive, proactive, non-pharmacologic care. The HELP strategies, it's a two-pronged approach.
And it really circles back to that core medical principle, doesn't it? First, do no harm, primum non nocere.
Exactly. It highlights the weight of every decision made, especially around prescribing. It's not just about fixing the surgical problem. It's about protecting the whole person, including their cognitive health.
So for everyone listening, here's something to maybe chew on after this conversation. Preventing delirium. It's more than just ticking off a potential complication on a checklist. It's about preserving who that person is, their thoughts, their memories, their connection to the world, their independence. It's about making sure they come out of surgery not just physically healed, but cognitively whole, ready to return to their fullest life. So how might knowing this change how you think about preparing for surgery, either for yourself or someone you care about? How might you advocate for this kind of holistic, medication-savvy care if you find yourself or a loved one in the hospital? Something important to think about.